is 21st Century Conversations. I'm Shani. Our program tonight is about gynecologic cancers. And with me to have this conversation are two wonderful people from Yale School of Medicine and a phenomenal audience from the community. I would like to welcome to the studio Dr. Peter Schwartz. Welcome.
Thank you very much.
Dr. Schwartz is a gynecologic oncologist, and he's from Yale School of Medicine. And Dr. Thomas Rutherford, welcome, who is also a gynecologic oncologist. And in fact, this is your second time with me. You were with me many years ago.
That's correct.
And to ask a lot of questions and to address these issues of cervical, endometrial/uterine, and ovarian cancers are some wonderful people from the community who are here to learn and to ask questions and to help the doctors to fine-tune their information-giving skills, right? Because you have a lot of people asking you questions tonight. Welcome to my audience. I want to thank enormously Susan Feldman from the Village of Power and Dawn Poindexter from the Abundant
Harvest Outreach Ministry.
Abundant Harvest Outreach Ministry. These are the 2 point people in getting people from the community to come in to participate, and I thank you all so very much. I also want to say tonight, we often take these programs for granted. We get on the air, and I don't always thank the people in the control room and behind the cameras. I want to make a special thank you to Don Fapiano, who for the past year has been getting us on the air. And I thank Don for his commitment to the mission of OneWorld and to our commitment to helping us to fulfill our commitment to educate and inform the community around health literacy issues. We thank the people who stand behind the cameras and those who do various things to help us to bring you these programs. And certainly, without the doctors here to inform us and make these programs so worthwhile, we just wouldn't be on the air. So I thank you two very much, especially after working all day. Okay, so now we're going to get right to it. We're going to talk about cervical cancer first. Much has been in the news recently about ovarian cancer and endometrial cancer, and sometimes the literature is a little confusing for us to sort through. And the doctors tonight are going to help us to sort through all that clutter and to get to pinpoint the key issues on which we should focus. So first we're going to start with cervical cancer and to ask you, what exactly is cervical cancer?
So the cervix is the portion of the uterus that sticks into the vagina.
Mm-hmm.
And if you think about a uterus, it looks like a light bulb with threads. And if you look at a cervix in a vagina, it actually looks pretty close to what the threads, only without the threads.
Mm-hmm.
That's the cervix. The uterus is inside the abdominal cavity. So when you think about a cancer of the cervix, you're talking about two specific types of cancers in particular. One being what's called a squamous cell cancer, which is the outside of the cervix, or the thread portion. And the other is called an endocervical, which is the canal that leads into it's the birth canal leading into the uterus, and that's a different type of cells called a glandular cell. So two specific types of cancers that we look at.
So the cervical cancer are two separate types of cancer?
Correct.
Uh-huh. Now, which one is more dangerous? Are they both equally dangerous?
That's a loaded question.
Yeah, that's a tough one.
That's my specialty, loaded questions.
The type that forms on the outside surface, the squamous cells, used to represent about 95% of all of these cancers. And its management was really based on how early or how late you found it. The glandular used to be harder to diagnose, and as a result, when you did diagnose it, it often was more advanced. And the more advanced stage cancers are harder to treat. So adenocarcinomas, these glandular cancers, got a very bad reputation. Some centers have studied the squamous cells and the glandular cancers, the adenocarcinomas, and shown that stage for stage and size, the tumors being of equal size, there is no difference. But often the adenocarcinomas, the glandular cancers, are not diagnosed early because they're harder to detect by pap smear. And so they're found more advanced at the initial diagnosis, and they may not do as well.
So, and of course, we know that the later you find the cancers, the more challenging it is to treat, and the less likely that you can treat it successfully over a long period of time.
That's correct.
Is that true?
That's correct.
Now, is either the glandular or the squamous cell cancer any more aggressive, or is just a matter of when they're found?
It's more a matter of when do you find it. So if you have a small lesion, earlier stage, that's a much better tumor.
Okay. What are the risk factors for cervical cancer?
Well, the classic risk factors were early age of first intercourse, multiple partners, children before age 18, lower socioeconomic group, and there definitely is some differences in ethnicity between the incidence of cervical cancers.
Now, we understand, I think most of us, the audience will agree with me, that we understand that if you have multiple partners, because the more partners you have, the more likely you are to pick up some sort of an infection if you have multiple partners. But why would lower socioeconomic group be a high-risk factor or a factor?
Well, it's been consistent throughout the literature, this finding. And the assumption is that, for whatever the reasons are, there are more partners, and therefore they have the increased risk.
So I see. So economic factors, if people are dependent on others, mainly if women are dependent on men for economic support, poor women are more likely, you're saying, to be engaged with multiple partners as a way of finding support.
Oh, I'm not saying that at all. Don't get me involved with that.
No, I'm asking. I'm trying to make sure that people don't, because that seems to be the sort of the immediate inference I would draw. And so that's why I'm asking, to make sure that other people don't draw that inference.
I don't think we really know, to be honest with you, to some extent. Some of it may be due to lack of screening, but even when you put the pap smears and bring it back in, it seems like the poor socioeconomic patient across the board does worse on cancers. So it may be diet, it may be stress in a home life.
Yes.
It could be access to care. It could be lifestyle, lifestyles that they are engaged in that might be different. I don't know if it's just one.
I think access to care is a critical piece. What do you guys in the audience think? You think access to care might be a significant factor in poorer women presenting at a later stage of cancer development, and therefore
I think we find that the Village of Power, that there's a distrust of formal institutions, a fear of going to a hospital, cultural differences, and issues of poverty, which really increase stress, decreased support such as good nutrition, and the fear of not getting what one needs from a cultural perspective really keeps women from seeking, women especially I know, from seeking help in a timely way.
Okay, that was Susan Feldman, who is the coordinator for the Village of Power, and Susan is a licensed clinical social worker and certainly works with a broad cross-section of people. Anything else? Do you guys have any question about cervical cancer so far? Yes, Vivian.
Yes, I want to know the relationship in obesity and fast food relating to cervical cancer.
Relationship, is there a relationship between obesity, fast food, and cervical cancer that you know of?
I'm not aware of that. The other factor we haven't, I believe, mentioned tonight is really human papillomavirus.
Yes, HPV.
HPV is highly associated with precancerous and cancerous changes of the cervix. But obesity and fast foods, as we get into uterine cancer, clearly is associated, but not with cervix, not to my knowledge.
Okay, tell us why the human papillomavirus is such a is such a challenge in terms of cervical cancer?
Well, it's a virus that has the ability to shut down the normal cell's mechanism for controlling cell growth and cell division. And the virus, it's a very simple organism, when it gets into the cervical cells, it allows the cells to lose their normal control about what stops them from dividing.
Okay, we're seeing on the screen that it says HPV also causes genital warts, and women do not often realize that they have HPV. Now, what does the genital warts have to do with, how does that affect the transmission of the disease?
If someone would have a genital wart, it's easily transmittable.
Oh,
Because the patient does, if you have genital warts or a high-grade pap smear or a cervical cancer, then probably 99% of those patients do have virus that can easily be transmitted to another partner.
can a woman tell if she has a genital wart? Is it something that is outside of genitalia or is it inside? Can she feel it? How would she know if she had a genital wart?
Well, if it's external, you can sometimes see it.
Mhm.
But you can also have the same type of lesion going on inside the vagina or on the cervix.
I
So
see.
sometimes, if it's externally, it's easy to see. Internally, if a patient has a lot of papillary growth, sometimes they can feel a change.
I see. I see. Do these rupture at any time? Because they don't rupture.
Not routinely, no.
Okay, so except for her being able to feel it, she might not even know she has them unless she goes for a screening, goes to the doctor and has an examination.
Correct.
Okay, which is another reason why the annual screening, for a pap smear and all this are so critical, because that's the only way some women might be able to tell if they have the human papilloma virus or if they do have any of these genital warts. So again, we come back to the point of how important it is to get screening, and come back to the point also about poverty and access to health care and the need to have health care available to everyone. Because without the availability of health care, poor women cannot get these screenings. It can cost an awful lot of money to go to the doctor if you don't have insurance. Okay.
That's right.
Go ahead, Sue.
An interesting thing we also find is that, for instance, many women at the Village of Power have dropped out of school. And schools are one of the places where people get educated on, personal hygiene and self-care.
Yeah.
And so I think what we're finding is there is a lack of education, and there's a lack of education going out into the community, informing women of the high risks and what to do about it. And then the barriers of poverty, lack of insurance, distrust of systems
Yeah.
creates even more distance between a woman and the care that she needs. So we're really looking at a public health approach, I think, to getting information out.
Yes, and which is why we do. I asked before we got on the air, I said, why do I do this? Because the challenges are so great sometimes to get these programs on the air. But again, exactly because I know there's a need in the community, and the Village of Power is just one place, but throughout our various communities there are these needs. And in this state, we have thousands of people. I think the last count I heard was over 40,000 people without health care at all. Okay, anything else you want to say about this?
Well, let me say that the warts are not an insignificant issue. There are about 1 million new cases every year in the United States of genital warts. So this is a common problem. This is not a rare thing. And you're right, it's a public health issue. Estimates about the cost to treat a wart range about, on average, around $1,000.
Wow.
So you can build up a very, very expensive situation if you have to treat these things. And when you get exposed to the human papilloma virus, the warts frequently appear within a matter of months, as opposed to the precancerous or cancerous changes of the cervix, which take years. So warts are a fairly quick appearing manifestation that you've been exposed to human papillomavirus.
I see. And again, Dr. Schwartz, that is emphasizing the importance of annual checkups. Because if you get an annual checkup, if the warts, are there for a couple of months and you discover them early, your chances of getting treated effectively are so much better.
Right.
Dr. Rutherford, we want to talk about signs and symptoms of cervical cancer.
Vaginal dysplasias and vaginal cancers or vaginal bleeding after intercourse.
Mm-hmm.
You can have bleeding between a normal menstrual cycle, or if you're bleeding after you went through menopause is often a worrisome sign.
Mm-hmm.
When you start seeing an advanced tumor, sometimes you have a foul odor,
Mm-hmm.
a watery discharge,
Mm-hmm.
or a fair amount of heavy bleeding. That's just continuous. When you start getting into pelvic pain, then we know that that tumor has spread out of the cervix and coming into the lateral side tissues. So it can affect the rectum, it can affect the bladder, it can affect the pelvic sidewalls, blocking the tube from the kidney to the bladder, causing some significant problems. It also puts pressure on the nerves that's come down into the legs.
So you can have pain in the legs.
Pain in the legs or a swelling of the legs tells us that's an advanced tumor.
One of the things that happen, again, and Sue is so right about people who are not informed and why education is so important and information is so important, because many women, especially women who are poor, women who have several children to take care of, women who are head of household and have to carry all the burden and responsibility themselves, will have pains, not just pelvic pain, but pain all over their bodies, and don't go to the doctor until they cannot function anymore, because they have to do all these other things before, taking care of themselves comes last because they have all these other things to do. So again, we want to stress to you to listen tonight to what the doctors are saying about signs and symptoms, that if you're having pain in the lower groin area and to the sides and shooting down into your legs, that you should really go to the doctor. And if you don't have health insurance, there are community health agencies. There's certainly the Hill Health Center, the Fairhaven Health Clinic. There is the Dixwell Health Center. There's Yale, New Haven. They have the residency clinics. There is a hospital of St. Raphael's. It's really important that you act proactively and go and ask questions and let someone know that you're not feeling well and get it checked out. You're better off being told it is not serious than to wait until it is so serious that when you go and get checked out, there's not much they can do to help you. So that's our piece for cervical cancer. Prevention, Pap test, right? The annual Pap test.
Correct.
And not smoking.
Correct.
Okay. Critical. Smoking has such effect in so many areas, on the heart, the lungs, the kidneys. Smoking is a really, really bad actor. So if you smoke, we want you to really try and before you leave here tonight, we have lots of literature in the conference room that helps you to tell you about how you can stop smoking. You can get help to stop smoking, because smoking is just a bad actor. Okay? All right. And if we seem to be moving quickly because we have a lot to cover, so we're going to go now to talk about endometrial, what many people also call uterine cancer. And you've sort of explained it to us a little, but tell us again, why is it that endometrial and uterine cancer seem to be called the same thing? And we have there a definition for you on the screen, and in the interest of time, I'm going to read the definition. Okay. Abnormal cellular growth of the endometrium, which is a tissue that lines a woman's uterus. Okay. Why is endometrial cancer so hard to detect?
It's actually not too hard to detect. It's one of the cancers that usually is found early, and it's usually found in postmenopausal women who start bleeding again. They get a little bit of spotting, and if they come to the physician, we can get a biopsy of the uterine cavity, and it's usually a pretty easy thing to detect.
Okay, well, here is the thing, Dr. Rutherford and Dr. Schwartz. In preparing for this program, I have received information from 3 families telling me about their young daughters who have endometrial cancer. One was 29 years old on July 6th of this year. She is very, very ill. She's in stage 4 endometrial cancer. One is 28, and one is 31. The 31-year-old was diagnosed when she was 27. The 29-year-old was underdiagnosed 2 years ago. Here is the story her mother reported to me. She was having unusually heavy bleeding when she was about 25 years old. The doctor she went to put her on birth control pills to regulate her period, did nothing else for 2 years until she started having cramps and pain in the lower abdomen. And when she came to Yale, after seeing a private GYN doctor for 2 years, she was diagnosed with very advanced endometrial cancer. So I consider that hard to diagnose if you went for 2 years and didn't identify it.
The overwhelming majority of women with endometrial cancer are postmenopausal. And so it's easy to pick up in postmenopausal women because the most common symptom is spotting or bleeding in the menopause. So those women, if they come in quickly, usually have early stage disease. 70% will have what we call stage 1 disease, and those 70% have a cure rate that approaches almost 100%. So for those ladies, that is not an issue.
Okay.
When one sees spotting, abnormal spotting or bleeding in a young age woman, such as the ones that you just described, the first thing a gynecologist is going to think about is cervical problems, and he or she will do a pap smear. The pap smear is not a good test for picking up endometrial cancer. It's an excellent test for picking up cervix cancer, but not uterine cancer. Now, those patients are unusual. 28, 29-year-old women getting cervical cancer, getting endometrial cancer, not routine. So one of the things that we really want to know about is their family history. And I bet you at least one of the 3 I know about.
Yes,
and
you do.
there is an outstanding family history of colon cancer and endometrial cancer. And there is a syndrome. It's called the Lynch syndrome.
The
It has
Lynch?
Lynch, Lynch 2 syndrome. It's named after Henry Lynch from Nebraska. The fancy name is hereditary non-polyposis colorectal cancer syndrome. And these are families that usually have 3 first-degree relatives who have colon cancer. The second most common cancer in those families is uterine cancer.
Okay. but
Family history is very important.
Yeah, but Dr. Schwartz, shouldn't her doctor or gynecologist know that and do the appropriate tests when she went to him at 25? Why treat her for 2 years with birth control pills and not do... So by the time she came, you know, to you guys at Yale, she was so far gone.
Well, I must say that physicians tend to treat the things that they think are most likely to occur first. And we see this abnormal bleeding in a woman in this age group
25
is
years old,
usually
yes.
regulated with pills, with hormonal therapy. And you cure them. You don't think about uterine cancer.
Okay.
But it's very important for all physicians to take a careful family history.
Yes.
That's the critical
And
thing.
this is what I want to say to you in the audience here and to my audience at home. This is why knowledge is so important. Your own knowledge and being proactive is so important. Because if that young woman had known that her family history, if any of these 3 young women had known that family history is so important, that birth control pill was not the answer, that they needed to dig deeper, then they would have been able to jot down some questions, talk to family members, and take it to the doctors. Again, I cannot stress to you how important it is for you to be proactive about your own. Doctors are good, but they're not miracle workers, and it is so important for you to inform yourself. I cannot stress that too much. How important it is for you to inform yourself and to take action yourself. Because these young women, and one of them I know very well, did not know any of this. Her mother didn't know it. And so she is now at age 29 in stage 4 endometrial cancer and very, very ill. So to my audience at home, really learn your family history. Speak to your grandmother and your grandaunt. Find out what did Aunt Sue and Sister Mary died from. Find out what killed your grandmother's sister, because those are still close enough. The gene pool are the same. Find out and really take proactive steps. Don't wait on the doctor to figure things out for you. Go to the doctor with specific questions. Okay, so one of the, so although it is most commonly diagnosed in postmenopausal women, in this little area, I know 3 women, 31 and younger, who have this disease. So to me, it's not 90%, because I really know less people postmenopausal who have this disease than I know people who are much younger than myself. Okay, all right, so what else do you want to say about this?
Well, the other thing that, as we see the population getting heavier,
Yes.
it's not uncommon to find a 25-year-old or a 30-year-old lady weighing 300 and 400 pounds.
Oh my God, yes.
And that has a major effect on the hormones, and the hormones really have a major effect on the uterine lining. So we're finding an increased number of patients at a younger age having an endometrial cancer based on diet.
Okay. Any questions about endometrial cancer, guys? Yes, go ahead.
Well, can diet bring on the cancer, or can it exacerbate a pre-existing condition?
If you look at the Japanese population where they eat a lot of smoked food, you see a higher incidence of stomach cancers. If you get a Japanese person to come to the United States, they quit eating the smoked fish, they don't get the stomach cancers. They come over and go to the fast food places, and the next generation you find the endometrial cancers. Okay, so it's sort of a loaded question. Did the diet per se cause the cancer? Not 100% directly. But I think it's a culmination of what we do with the diet and the lack of exercise and, our what we do as a society as far as exercise and how little activity we do anymore today.
So physical activity is very important in so many things. And many of us say, we don't have time to go to the gym. But I don't think my grandparents ever heard the word gym. They didn't know what it was, but they were so centered because they walked. They walk a lot, and we don't have to go to the gym. I certainly don't have time to go to the gym. But I think walking, instead of getting on the bus on the corner, if you're going 3 blocks, if it's a nice day, I think walking is a big help. And for us women, as we age, walking also helps to strengthen the bones, and to maintain bone mass. So there are so many good things we can do walking. It's so many benefits, okay, for walking. Any other questions? You guys in the back are very quiet. I know you asked a lot of questions before, but any other questions back there? Okay. All right. Let's go to the next slide. We just want to run through some of the key things for people to understand about endometrial cancer. So although it is most commonly diagnosed in postmenopausal women, young women do get endometrial cancer. And that's really important for us to talk about. Now, 40,000 women are diagnosed annually in the United States. And what is the treatment for endometrial cancer?
Well, the standard treatment is to remove the uterus, and in addition, the tubes and ovaries. And following that, some experts have different ways of approaching it. Often now, we will take out the lymph nodes in all but the most early, most well-differentiated, we call it, most indolent type of cancer. We will be taking out the lymph nodes that drain the uterus and extend up into the periaortic area. So it's a hysterectomy, which is the removal of the uterus, including the cervix, the fallopian tubes and ovaries, the pelvic lymph nodes, and the para-aortic lymph nodes. And then based on the final pathology report, some form of radiation may also be recommended. At Yale, which is a major center for uterine cancer management, we would routinely use some local radiation to the top of the vagina to prevent recurrence at that one site, the most common site that these cancers come back.
And is that because the radiation will kill the cells that exist already there to prevent them from growing back into other tumors?
It may very well be that. It's always a debate, are you attacking cells that may have spilled out of the uterus?
Yes.
or is it cells that may have gone through the lymphatics? No one knows for certain, but the reality is that ever since we've kept statistics on this, the top of the vagina, where the cervix was separated from the vagina when you do the hysterectomy, is the single most common site for these cancers to come back. And some very local radiation that almost causes no symptoms at all prevents that from happening.
Okay, so surgical removal of the uterus is called a hysterectomy, and that is combined with radiation therapy. That's the most common treatment. But it's important for us to remember that over 40,000 women are diagnosed with endometrial cancer annually in the U.S. And I think, according to my research, about 7,000 die.
Yes.
That's
From
correct.
this? Okay. So again, folks, it's really, really important to get those screening tests. Okay. Now, the risk. Let's talk about the risk.
Okay, when you look at the cancers that come together in a group, again, are the colon cancers, the uterine cancers, the breast cancers. And with the breast cancers, many times the patient will use a drug called tamoxifen.
Yes.
Okay. That tamoxifen seems to have an effect on the uterine lining, and many times we find a very aggressive cancer in the uterus
Oh, my
that's
Lord.
associated with the tamoxifen.
So you're telling me that we take tamoxifen to cure breast cancer, and we end up getting...
Well, you sort of take the risk, you weigh the risk and the benefit. What definitely the tamoxifen has done is decreased or eliminated the recurrence of the breast cancer. And the problem with it, you get a small percentage of patients that have a problem with the tamoxifen on the uterus, and then you have to worry about a uterine cancer.
Now, does it matter how long you take the tamoxifen for? Is it, because I know that in some cases, you know, if you take medication for a short amount of time, it works well and you don't seem to have the long-term, like estrogen.
Correct.
You know, I mean, my mother went on estrogen and never got off, and she ended up with breast cancer. So the question is, how do doctors help patients to understand, or how do they determine which patients should take tamoxifen and which should not? Does that have something to do with the ER
It
receptor
has to do
genes
with
and all that?
estrogen. There's basically 3 different types of breast cancer currently. One of the types that you look at as far as treatment types, what you're looking at, does that tumor has an estrogen receptor? Okay. If you have a breast cancer with an estrogen receptor, the tamoxifen acts as an anti-estrogen. Okay? And what you want it to do is to actually shut down the effect of the estrogen, and the effect of estrogen is to make something to grow. So the tamoxifen will shut down that cancer cell and make it not grow.
So for those patients with this ER receptor 2, it's good to take tamoxifen. But do we know if you should take it, say, for 12 months, 24 months?
It's usually 5 years.
Oh, 5 years.
Let me try to handle that a little bit, okay?
Okay.
It dramatically reduces the likelihood of getting cancer in the opposite breast, and it prolongs the disease-free time period if, God forbid, you're going to have a recurrence of the original cancer.
Okay.
Those 2 factors, the reduction in the contralateral breast, the opposite breast getting cancer, and the prolonged disease-free period, far, far outweigh any risk to the uterus. But the risk to the uterus is there. The people who take tamoxifen are not only women who have breast cancer, but there are women in high-risk families with such high risk that the National Cancer Institute supported a prophylaxis trial to prevent the development of breast cancer. And these are women with very, very high risk.
And when
it
we say
works.
high risk, let's tell our audience, both at home and here, when we say high risk, you're talking about women whose mother or father had breast cancer, or grandparent or sibling, aunt or uncle.
Yeah. First-degree relatives with
First-degree
multiple
relatives.
first-degree relatives and second-degree relatives with breast cancer, and those who have had documentation of having a mutation in one of 2 genes. You mentioned your
Yes.
brother, I think it was. Male breast cancer is usually associated with mutation of BRCA2 gene.
Yes.
But BRCA1 gene mutations are much more common than BRCA2. So if you're in one of those families, tamoxifen may play a very, very important role in trying to prevent breast cancer.
Okay.
The usual treatment was 5 years. But now there are studies that show if you use it for 2 years and then change to another drug called Arimidex or
Yes.
aromatase inhibitor, the third generation, these are androgen inhibitors, prevent estrogen from being made. So they work differently than tamoxifen, but they seem to do at least as good a job, if not better, when they follow 2 years of tamoxifen with at least 3 years of these aromatase inhibitors.
Okay, first I want to ask my audience. Yes, you have a question back there.
Yes, when you were speaking about the treatments for the endometrial cancer, the removal of the uterus,
Yes.
sometimes the lymph, at what stage is that? Because that seems a bit aggressive. I mean,
She's talking about the total when we remove these fallopian tubes and the ovaries and everything.
is there another? Because I remember when I was, diagnosed with the fibroids, that was one of the first things that they were saying they were going to do. They wanted to remove the uterus, and it was almost as if I didn't have a choice. But I pushed the issue. I said there had to be another option. I felt that was, just way too serious. I was on 46, 45. I really didn't want to have my uterus removed so early. And if I hadn't have did the research and found out about the uterine embolization, they would have never done that. So I'm just wondering, that seems so aggressive. What is there in the beginning stages, if you catch it on time, that can be done other than all that invasive surgery?
Great question, because I want to just piggyback on what she says. One of the things that one of the challenges that many women face, and I think this is probably very true for and I don't know, but I know it's very true for Black women and Hispanic women. This thing about removing your uterus when you're young,
Yes.
is a major psychological issue, because it says something within your culture about you not being all woman anymore. Don't you guys agree with that?
I just didn't want to go through the changes, honestly. The
Yes, and they don't want to go through the
physiological
change,
changes. I wasn't ready.
menopause so early. Yes. So that's a great question. Thank you.
Well, the problem with the uterine cancers, we talk about a stage, and the way the cervical or the way the uterine cancers are staged are based upon the findings at surgery. The only way you can tell has that cancer spread is to take the uterus out and send it down to pathology.
Wow.
They need to slice it up and look at it and see how far has it invaded did it invade from the lining into the muscle? Did it go to the ovaries? Did it spread to the lymph nodes? We also do a washing of the abdomen with some saline and send that as well. Has it spread out the fallopian tubes? Is it in the abdominal cavity? So people say, yes, I have an early endometrial cancer, but you don't really know that totally. Now, we do have every now and then you have a young patient that you get a biopsy of. It's a well-differentiated cancer, and we look at what that tumor looks like, and if we're satisfied that it's real low grade, you can do a real good scraping of the lining of your uterus. You could actually look into the uterus and see it's one small lesion. That person may want to go to have children. We can do some hormone manipulations to see if we could get her pregnant and maintain the uterus. The risk you run is that tumor can be already outside the abdominal cavity and you don't know it. So as long as somebody's willing to accept that risk, we can do a hormone manipulation if that person's going to go on to have children as soon as we get this, the cavity that we're satisfied with. But there's still a risk doing that.
And can I just add something? I think in the interest of time, because we still have to get to ovarian cancer, I so understand your question, but I think one of the things that medicine and Dr. Rutherford and Dr. Schwartz, I'm stepping on your territory here, but I think doctors want to be successful when they treat patients. They want to be successful. They want the patient to survive. And one of the reasons that they go with this, what seems so aggressive sometimes, is because depending on some of the other signs you see when you do all this what we call debulking and stuff like that in the abdomen, is that you don't want to leave any cancer cells behind to grow again, right? So by cleaning out everything, you reduce the risk of a recurrence of the cancer, and especially for someone 45, because you expect the person to live for quite some time, and the chance of the cancer coming back is greater the longer the person lives, right?
That's true.
Okay.
Okay, can I make a comment?
Sure, please.
Okay. Cancer is a terrible disease, and you have one chance to cure it. It's your initial treatment. There are many diseases where you can try a drug, and if it doesn't work, you'll try another drug.
Yes.
You can do a local biopsy or something, and hey, if it comes back, you just take it off again. Cancer doesn't give us that opportunity. So you don't want to short-circuit your treatment because you're concerned about something. You really want to discuss that with your doctor, whatever it might be. But I have to tell you, if you don't have the right treatment the first time, it becomes a serious, life-threatening problem when that disease comes back again, if it's a cancer. So you've got to listen to the physicians as well. We do like success,
Yes.
but we don't like failure.
Right.
And you don't like failure either, I can assure you, if you're in that circumstance. So you want to get the best treatment. You should never hesitate to get a second opinion. I really strongly believe in that. Get a second opinion if you don't like what you heard from the first doctor. That you may be blaming the messenger, but you really want to understand what are the risks that you're taking if you're not going to have conventional therapy. It's really very important for you.
Okay, we're going to move on. I just want to close out this section by saying, in terms of endometrial cancer, in addition to the taking tamoxifen for a long time to prevent breast cancer, taking estrogen alone is one of the other risk factors, and being overweight and eating a high-fat diet. So being overweight, eating a high-fat diet, taking tamoxifen long-term, all of these are some of the risk factors. But again, we cannot stress enough the importance of screening, of getting your annual checkup, and whether you have health insurance or not, I say please go to one of the community health centers and try and get your screening, your annual screening, especially for women over the age of 40. And Black and Latino women in particular, because we tend to get more aggressive forms of cancer, and we tend to present at a later date when the cancer is more advanced, and the more advanced it is, the harder it is to take care of it successfully. Okay, we're going to move on to ovarian cancer. And ovarian cancer is an abnormal cell growth that begins in the ovaries, and I'm saying this again in the interest of time. So let's talk, do you see this up there? Yes. We want to show you the female reproductive system, and both you guys tell us what's the key pieces here that we need to understand.
If you look at the top, on the top right, we see the ovary. The ovary is probably about the size of half your thumb,
Okay.
normal size. And on the ovary is called the fallopian tube, and those are attached to the sides of the uterus. You have a right and left fallopian tube and ovary, and they're attached to the right and left side at the top of the uterus. And that uterus, you can see it, the bigger portions inside the abdominal cavity.
Yes.
It lies right below the bladder.
It looks like a baby curled up.
Yeah, a little bit. Yeah.
Yeah, okay.
And posterior is the rectosigmoid coming down into the anus. And if you look right down in the midpoint, right at 6 o'clock, is the vagina. And the vagina is a cylinder that if you look into, you look at the cervix. It looks like a cork with a hole in the middle.
Yes.
And you see the outside of the cervix is what is the squamous that we talked about before. And you see
Where those cells start.
those cells start. And then the hole in the cervix going into the uterine lining or uterine cavity is the endocervix. So it's all one continuum.
Boy. Okay, so that's the female reproductive system. And now we're going to ovarian cancer. Tell us, ovarian cancer is the number, what, 4 cancer?
Well, actually, it's number 7.
Number 7, okay. So tell us what we need to know about this and how we can prevent it, or, you know, if we get it, or we can get treated effectively. Tell us how, I know we have three types. There are three different types. Ovarian cancer is classified into three different types. We have the epithelial tumors, germ cell tumors, and sex cord stromal tumors. Okay. Tell us now, which of these are the most critical? We have 10 minutes to go.
Okay, the epithelial tumors are the ones that are the common cancers of the ovary. They represent roughly 90% of all ovarian cancers.
Wow, okay.
So they occur mainly in women as they get older. And in reality, the peak age years for epithelial ovarian cancers are age 75 to 79. So it's a risk, aging is an important risk factor for these cancers. The germ cell tumors, those tumors occur in young age women. The germ cell refers to tumors that appear to develop from the egg. So you have to have eggs. So if you go through menopause, no germ cell tumors.
Okay.
Mainly it's teenagers and women in their early 20s. Okay. Just another advantage.
Yes.
Okay. The sex cord stromal tumors are divided into two different types, but one type makes hormones, and the other type is just mainly fibrous connective tissue. So you don't really see many of those as far as malignancies go. Okay? Altogether, the most common tumor that women get are really dermoid cysts, and they're benign germ cell tumors, and they occur in reproductive age. But it's the common epithelial cancer. When people talk about cancer of the ovary, that is what we're talking about.
Okay, so the epithelial. Can't see without my glasses. Okay, so tell us about what we need to be concerned about here. So we know that they're developed from cells, yes?
Okay, so this is a cancer that we really don't see a precancerous change. If you remember when we talked about pap smears, or we should have been, pap smears for cervical cancer, what you're trying to do is pick up the precancerous change so that you can be treated in the office, and you can go on, and you can have children, and you're going to be cancer-free. We don't recognize that kind of change in the ovaries. So overwhelmingly, ovarian cancer is found as advanced stage cancer. 70% of the ladies have what we call stage 3 or 4 disease when they come into the doctor's office.
That's why so many people die.
That's right. It has a very high mortality rate.
Yes.
So the patients who we may know in advance have an increased risk for this disease are really those who have a strong family history, very much like breast cancer. The same genes, the BRCA1 gene and BRCA2 gene.
It's interesting to notice women who have never been pregnant is at high risk for this. Okay, so go over those for me. So the BRCA1 and the BRCA2.
These genes are mainly associated with breast cancer. Remember, breast cancer is the #1 cancer that women get in the United States. This past year is about 180,000 cases.
My God.
Ovarian cancer was only 22,000 cases.
But 15,000 die of ovarian cancer.
That's the problem with ovarian cancer, because it's not recognized early.
22,000 get it and 15,000 die. That's a tremendously high mortality rate for the percentage.
Right. It's the 3rd worst ratio of deaths to new cases. The only diseases that are worse are pancreatic cancer and lung cancer. So ovary is #3 in that regard. Now, it seems to be affected by the number of ovulatory cycles a woman experiences in her lifetime. So the more the ovulatory cycles you have, the greater the chance of developing ovarian cancer.
So women who start their menstrual cycle very young and have menopause very late are at greatest risk.
They are at great risk, but it's women who have had no children who are at the greatest risk.
Oh.
A woman in Connecticut who has had no children has 5 times the risk of someone who has 5 or more kids. Somebody with 1 or 2 children has twice the risk of somebody with 5 or more children.
Oh dear, I know I should have had more kids.
When you're pregnant, you don't ovulate, okay?
Yes.
And so that seems to be the single most protective effect. If
Did you hear that, guys? That's really, really a critical piece of information to have. When you're pregnant, you're not ovulating. Therefore, you have less ovulation cycles and less chance of getting ovarian cancer.
If you breastfeed postpartum, you prolong that period that you don't ovulate.
So does that mean that poor women who have a lot of children are less likely to get ovarian cancer?
Absolutely.
There's one good thing for being poor, I'm telling you. Okay.
The other thing you want to do is to reduce your risk. You have 2 ways to reduce your risk of ovarian cancer.
Yes.
One is birth control pills, because it prevents you from ovulating.
Uh-huh.
Okay? And the second, actually, we don't understand why, but it's a tubal ligation, to where we tie the tubes
Time off your tubes.
at the age of 35, or before the age of 35. Seems to have the most benefit.
So do you recommend that for women who are in high-risk categories have several ovarian incidents in their family? Ovarian cancer in their family?
I think they should be on birth control pills until they decide to become pregnant. That it start as soon as they're 16, 18, wherever they start menstruating.
Wow.
And then
Okay.
have your family, and then to reduce your risk further, you would look at a prophylactic removal of the ovaries.
My goodness. I want to say, time is against us. I want to say to my audience and to you here, ovarian cancer symptoms, and against in the interest of time, pelvic or abdominal pain or discomfort, gas, nausea or indigestion, frequency or urgency in urination. Geez, but this is also a symptom of people, so many people get older. You know, this could make people go crazy if they, because as you get older, frequency or urgency of urination becomes an issue for many women.
The symptoms will come and go, though. A lot of
Okay.
times you'll eat dinner and you'll have indigestion, and it goes away.
Mm-hmm.
And then a week later, it's I shouldn't have had the tomato sauce, and a week later I shouldn't have the fish, but before this you never had a problem. So it's the symptoms that persist is when you need to be seen.
Okay, changes in bowel habits. I would really like for you to go through that for me and stress to my audience the importance of paying attention to these things.
Anytime you have a change in how you function, you're going to have a change in your bowel, your bladder. You're going to have a weight loss or a weight gain, because we can get a lot of fluid with the ovarian cancers.
Yes.
You're not able to eat. Instead of eating 2 sandwiches, you're eating 2 bites of a sandwich.
And you feel full.
And you feel full.
Ah, yes.
Okay? If you start having pain, and it's and it's not like I'm exercising or I'm lifting or doing the curtains, you never had those problems before. If you have a change in how you are today, that's persistent.
Yes.
These persistent changes are what you need to pay attention to.
And abnormal bleeding.
Can cause abnormal bleeding if it's eroding through either the fallopian tubes or bleeding into the uterus or in the top of the uterus.
Okay. When you visit the website, the OneWorld website, you will get a lot more contact information for the Yale Cancer Center. You will get for the American Cancer Society. We have that on the screen for you. Please visit oneworldpi.org. That's, you put your 3 W's, oneworldpi.org, in order to get more information about this. Much of the information that we couldn't show you on the screen will be on the website. Do you guys have any last question? Yes, go ahead.
You spoke earlier about preventive measures for cervical cancer, but we didn't mention having the multiple partners and how that could affect you having cervical cancer. Can you speak on that?
It's always best not to have multiple partners, because not only are you with that partner, but you're also with the partners that partner was with. So if that partner has 3, 4, 5 partners, and you're his only partner and ever his only partner, you still now have 4 partners.
Yes, yes, that is such a good point. That is such a good point. So it's not that you are, running around having multiple partners, but if you have someone who is not faithful to you sexually, then whomever that person sleeps with, you're also sleeping with them technically. Because whatever disease is that that person contracts is passed on to you. I'm asking you, first, I'm so grateful to all of you for being here. I thank you so much. Please thank the doctors for me. Please give them a round of applause. I thank you both so very much. Check our media page on the website to see where else our program airs. We air in many different cable systems. Again, I want to thank the people behind the cameras in the control room. I thank you so very much for being here tonight and helping us to get this program on the air. Dawn Points Dexter, Sue Feldman, Susanna Ling Yale, all of you whose name I don't know, Miss Vivian, Roslyn, I thank you all for being here. And please, knowledge is power, get informed. Keep watching, learn. You don't have to have a college degree to learn about how your body works. Write questions down and call up your clinic or someplace, ask questions, learn all you can, and you can help to protect yourself. And if you have symptoms, don't wait until you're in bed sick, can't move, okay?
Yes.
Get help, get the help you need. We need you all around to be healthy and strong, because without you, where would I be tonight? Thank you all so very much.